Welcome to MedSEMA Medicine Podcast. This is our very first episode, and we're diving deep into a fascinating condition today, Myasthenia Gravis. We'll be unpacking what it is, how it presents, and, well, how we as medical professionals actually approach it.
Yeah.
Think of this as your focused review, hitting the key points and maybe some of the more nuanced bits relevant for your studies and, practice in emergency medicine.
That's right. We have a fair bit to get through, actually.
Yeah.
Covering everything from those initial clues in a patient's history
Right.
all the way to the critical management decisions we face.
Right.
The goal really is to boil this down to the essentials.
Make it clear.
Exactly. So you come away with a, hopefully, clearer understanding of this pretty important neuromuscular disorder. Useful for exam prep, but also just for clinical practice.
Definitely.
We'll touch on the classic presentations, those tricky differential diagnoses you really need to keep in mind, and the key investigations that kind of guide how we manage things.
Okay, let's jump in then. History first.
Let's do it. So history, myasthenia gravis, it's fundamentally an autoimmune thing. You get muscle weakness, and that's because antibodies are messing with the communication.
At the neuromuscular junction.
Precisely, at the neuromuscular junction. So the classic way this shows up is through, well, several key symptoms. One you almost always think of is ptosis.
The drooping eyelids.
Yep, drooping eyelids can be one side, could be both, often a bit asymmetrical, especially when it starts. And the really characteristic thing...
Gets worse as the day goes on.
That's the one. Worse in the evening or after they've exerted themselves.
Mm-hmm.
And that's down to those anti-acetylcholine receptor antibodies interfering with the signal getting to the levator palpebrae superioris, the muscle that lifts the lid.
Okay.
Then another really common one is diplopia, double vision.
Right, from the eye muscles getting tired.
Exactly. Fatigue in those extra-ocular muscles.
Hey.
Patients might also mention difficulty chewing. That points toward the muscles of mastication being involved.
Right.
And similarly, swallowing can get tough. That's fatigue of the bulbar muscles. And interestingly, these bulbar symptoms, they can be linked to either the anti-acetylcholine receptor antibodies or sometimes anti-musk antibodies.
Ah, okay. So different antibodies can cause similar bulbar issues?
They can. And, you often hear about difficulty lifting things or even just standing up after sitting. That suggests weakness in the shoulder and pelvic girdle muscles.
Limb girdle weakness.
Mm-hmm. And then the really serious one we always worry about, breathing difficulty.
Myasthenic crisis.
Yes. That means severe weakness affecting the oropharyngeal muscles, the diaphragm, accessory muscles. It's a true medical emergency. Always need to be vigilant of that.
Absolutely. So what about on examination? What signs should we look for?
Right, the exam. There's some pretty specific signs. The positive peak sign is a good one.
How does that work?
So you ask the patient to shut their eyes really tight, hold them shut. After a few seconds, because the orbicularis oculi muscle fatigues, their eyelids might start to involuntarily drift open slightly, like they're peaking.
Okay. Makes sense. Fatigue.
Then there's the Kogan lid twitch sign. Bit more dynamic. You have them look down for maybe 10-15 seconds.
Okay.
Then quickly look straight ahead. As the levator muscle re-engages, you might see this exaggerated upward twitch of the upper eyelid.
Interesting.
And related to the ptosis, there are a couple of other neat, well, maybe slightly confusing signs initially. Paradoxical reversal of ptosis with edrophonium.
With tensilon.
Yeah, with tensilon. So say the patient has a ptosis in one eye. You give edrophonium, that eye gets better, the ptosis improves. But the other eye, the one that looked fine, might suddenly start to droop.
Why would that happen?
It's thought to be Herring's law of equal innervation. Basically, the brain was sending extra signal to both levator muscles to try and lift the droopy one. When the affected side improves with the drug, that extra drive relaxes, and the previously normal side reveals its own underlying fatigue or just loses that compensatory tone.
Huh. Okay, that's subtle.
It is. And enhanced ptosis is similar. If you manually lift the luptotic eyelid.
Just lift it with your finger.
Yeah. The other eyelid might then start to droop again because that compensatory overdrive signal from the brain is reduced. Herring's law again.
Got it.
You might also hear their voice deteriorate if you ask them to count, say, to 50. Reflects bulbar muscle fatigue affecting phonation.
Voice fatigability.
And in really long-standing disease, you might actually see some muscle wasting, though that's less common early on. Reflexes are usually normal.
Which is a key point differentiating from some other neuromuscular conditions.
Absolutely. Though sometimes you might see the reflexes fatigue if you elicit them repeatedly.
Okay, so we've got the history, the exam signs. What about differentials? What else could this look like?
Crucial point. Lambert-Eaton myasthenic syndrome, LEMS, is probably the big one to differentiate.
Right.
And the absolute key difference, in LEMS, weakness actually improves with repetitive movement, at least initially. It's the opposite of MG.
Opposite pattern of fatigue.
Exactly. Also, look for autonomic symptoms in LEMS, dry mouth, constipation, maybe postural hypotension. And often, gait difficulty is an early feature. Plus, there's that strong link to small cell lung cancer.
And different antibodies, right? Voltage-gated calcium channels.
Spot on. Antibodies against the presynaptic voltage-gated calcium channels, which stops acetylcholine release. Completely different mechanism, really.
Okay, LEMS. What else?
Botulism. Definitely one to consider, especially in the ED.
Foodborne or wound?
Could be either. Think about GI symptoms if it might be foodborne, or maybe a history of IV drug use for wound botulism. The key differentiator clinically is usually the pattern of paralysis. Botulism typically causes a descending paralysis.
Starts high, moves down.
Yeah, often starts with cranial nerves, blurry vision, diplopia, dysphagia, dysarthria, then moves down to the limbs and respiratory muscles. MD is often more generalized or might start ocularly, but doesn't usually have that strict descending pattern. And again, different mechanism. Botulinum toxin blocks ACRE release presynaptically.
Good distinctions. So how do we confirm the diagnosis of MG? What tests do we order?
Right, investigations. Serum antibodies are a cornerstone. Anti-acetylcholine receptor antibodies, the AChR antibodies, they're positive in like 90% of generalized MG cases.
Pretty high yield.
Very. And around 75% in purely ocular MG. Those are negative, especially in generalized MG. You then look for anti-MuSK antibodies, muscle-specific kinase, found in maybe 40–50% of the AChR negative generalized group.
Okay, so antibody testing is key. What else?
Electrophysiology, repetitive nerve stimulation, or RNS.
What does that show?
You stimulate the nerve repeatedly and record the muscle's response, the compound muscle action potential, or CMAP. In MG, you typically see a decrement. The CMAP amplitude gets smaller with successive stimuli, showing that neuromuscular transmission is fatiguing.
The signal drops off.
Exactly. You might also see post-tetanic potentiation, a brief improvement after a short burst of high-frequency stimulation, followed by post-exercise exhaustion. But you need to remember, RNS isn't perfectly sensitive. It's positive in about 75% of generalized MG, but only around 50% in ocular MG.
So it can miss ocular cases quite often.
It can, which is why, if you still have high suspicion, especially in ocular MG, the next step, electrophysiologically, is single-fiber EMG, or SFMG.
That's the really sensitive one.
That's the one. It's positive in over 95% of both generalized and ocular MG. It's technically more complex, but it measures jitter. Yeah, it's the variability in the timing between the action potentials of two muscle fibers innervated by the same single motor axon. In MG, that transmission is unreliable, erratic, so the jitter increases significantly. It's a very sensitive measure of neuromuscular junction dysfunction.
Okay, SFMG for high sensitivity. What about older tests like tensilon?
The tensilon test, using edrophonium, it's still sometimes used. Edrophonium is a short-acting acetylcholine esterase inhibitor, so it briefly increases acetylcholine at the junction. If the patient's symptoms, like ptosis or muscle strength, transiently improve right after injection, it's suggestive of MG. But, it has risks, cardiac side effects, and false positive negatives can occur.
Needs careful monitoring.
Definitely. Atropine needs to be on hand. The ice test is simpler, safer, especially for ptosis.
Right, just putting ice on the eyelid.
Yeah, apply an ice pack over the ptotic eyelid for a couple of minutes. If the ptosis improves noticeably, it's a positive test. The cold is thought to inhibit acetylcholinesterase activity locally, improving transmission. It's quite specific if positive.
Useful bedside clue.
And finally, you'll almost always get imaging of the chest, specifically a mediastinal CT scan.
Looking for the thymus.
Exactly. Looking for thymic abnormalities. Yep. About 65% of MG patients have thymic hyperplasia, and maybe 10 to, some say, up to almost 30% have a thymoma, a tumor of the thymus. The rest might have a normal or involuted thymus.
And that has treatment implications.
Big time. We'll get to that. Oh, and you usually check things like CPK and ESR just to help rule out inflammatory muscle diseases, but they're typically normal in MG.
Okay, comprehensive workup. You mentioned thymectomy. Are there specific things to consider there?
Yeah, if thymectomy is planned, especially under general anesthesia, preoperative spirometry is really important. We need to know their baseline respiratory function because they're at higher risk of postoperative respiratory complications.
Makes sense. And how do we monitor disease progression, particularly respiratory status?
Force vital capacity, FVC, is key. Regularly measuring FVC helps track respiratory muscle strength. A significant drop can warn you that they might need respiratory support, like intubation.
Proactive monitoring.
Absolutely. And even simpler, at the bedside, you can do a single breath count. Ask the patient to take a deep breath and count out loud as far as they can. If that number starts declining significantly, it's another warning sign of worsening respiratory muscle weakness.
Useful practical measure. And if a thymoma is found on that first CT?
Then you typically proceed to a full chest CT for proper staging of the thymoma itself.
Right. Okay, let's talk management. General principles first.
Okay, management. First, identify and, where possible, treat or avoid triggers that can cause a relapse or exacerbation. This is huge for patients.
What are common triggers?
Oh, lots of things. Infections are a big one. Pneumonia, even just a URI. Certain medications are notorious. Aminoglycoside, antibiotics, magnesium sulfate.
Often given in the ED.
Exactly. Need to be cautious. Also beta blockers, certain antiarrhythmics like procainamide and quinidine, opioids, barbiturates. The list is quite long. Need to check carefully.
Good point. Other triggers.
Stress is a major factor. Physical stress, like surgery or pain, lack of sleep, even emotional stress. Temperature extremes can do it. Sometimes hormonal changes, menstruation, pregnancy, childbirth.
So patient education on triggers is vital.
Absolutely. And, of course, a core part of management, especially in acute settings, is recognizing the need for intubation and ventilation early if respiratory failure is developing. Don't wait until they crash. Continuous monitoring is essential.
Preemptive action.
Definitely. Now, for specific treatments, symptomatic relief usually starts with oral anticholinesterases. Pyridostigmine is the standard one.
Like tensilon, but longer acting. Boosts acetylcholine.
Right. It helps improve muscle strength by making more acetylcholine available at the junction. But crucially, it doesn't treat the underlying autoimmune disease.
Just manages symptoms.
Correct. And getting the dose right can be tricky. You have to balance the benefit against side effects like GI upset, diarrhea, cramps, excessive salivation, or secretions. It's often a process of careful titration.
An art, sometimes.
It really can be. Then, to target the underlying autoimmunity, especially for relapses or if pyridostigmine isn't enough, we use immunosuppressants.
Like steroids.
Prednisolone is often used first line for immunosuppression. Longer-term options include azathioprine or mycophenolate mofetil, which are steroid-sparing agents.
And thymectomy.
Thymectomy can definitely improve the long-term prognosis, particularly in younger patients, typically those under 60 or so, with generalized MG who are AChR antibody positive, even without a thymoma. If a thymoma is present, surgery is generally indicated regardless, though the presence of thymoma itself carries a somewhat worse prognosis for the MJ.
Okay. And what about for acute crises, when things get really bad quickly?
For severe exacerbations or myasthenic crisis, we need rapid treatments to remove the harmful antibodies. The main options are plasmapheresis or plasma exchange, PLEX.
Filters the antibodies out of the blood.
Essentially, yes. Or intravenous immunoglobulin, IVG.
Modulates the immune system.
Right. Both work relatively quickly, over days. PLEX is often considered a bit more rapidly effective at lowering antibody levels, but it carries more risks. Requires central access, potential for hemodynamic instability, citrate toxicity. IVG is generally easier to administer and might have fewer acute risks for some patients, though side effects like headache, fluid shifts, and rare thrombotic events can occur. The choice often depends on the specific clinical situation and local expertise.
Complex decisions and critical moments. So as we've explored, myasthenia gravis really is a fascinating clinical puzzle, isn't it?
It really is.
From those sometimes subtle initial clues in the history and exam, through the strategic workup with investigations, and then tailoring the management, it demands a pretty comprehensive approach.
Absolutely. And really understanding those nuances, especially the differential diagnoses like LEMS and botulism, that's just crucial for making good decisions, particularly when you're working under pressure in an emergency setting.
Yeah.
And remembering those key investigations, the antibody tests, RNS, and especially that highly sensitive SFG, they really provide vital pieces of the puzzle to confirm things.
Well, we hope this deep dive has been a valuable review for everyone listening, maybe sparked a few aha moments in understanding myasthenia gravis.
Hope so.
Join us next time on Medicine Podcast for another in-depth exploration of a key medical topic.